Welcome to the APAP podcast. My name is Corinne Young. I'm your host today, and I'm the president of the Association of Pulmonary Advanced Practice Providers, or APAP. And with me today is Brian Rose. He is a cardiovascular physician assistant in Fayetteville, North Carolina. He has been part of a large private cardiovascular group for over 6 years. His focus is primarily on general cardiology, including the management of congestive heart failure and pulmonary hypertension, but has dedicated a majority of his time to PAD and management of critical limb ischemia, which I didn't even know was an area to specialize in. In addition to being a full-time clinician, Brian still participates in clinical research and currently serves as an assistant professor for the Methodist University PA program. He is the president-elect for the Association of Physician Associates in Cardiology, or APAC. And today, I'm going to be picking Brian's brain in hopes of better understanding that intersection where cardiology and pulmonology meet. So Brian, thank you for agreeing to let me take out all of our cardiology angst on you that we have from the pulmonary side.
Well, thank you, Corinne, for having me. Pulmonary hypertension is something that I will say when I started practice, didn't really understand very well, and really it's evolved in the last 6, now going on 7 years in practice, and it's given. I find this our discussion this evening so fitting, talking about collaboration, because that's what I've really been forced to do in my area with pulmonology, with even in some of these more exotic cases of pulmonary hypertension with other groups like cardiothoracic surgery and rheumatology, infectious disease, and what have you. And we'll touch on all of those. But thank you very much for having me.
Of course. You know, we did a podcast earlier this year with rheumatology, and because there is all this overlap in our disease states. And so we're so excited to have you. And I kind of want to jump right into the two things that I think really mystify us on the pulmonary side, and that is when we have a breathless patient, their pulmonary exams seem to be fairly normal. Pulmonary risk factors may be none or very little, and the patient's very breathless when they exert themselves. And so we start looking outside the pulmonary exams, and we'll do an echo, and we see valvular disease, we see HFpEF, and for those of you that may not be familiar with that term, heart failure with preserved ejection fraction, so their EF is good, but they have some evidence of maybe diastolic dysfunction, grade 1, 2, 3. And then we are stuck kind of in this quandary of how much valvular disease, how much HFpEF do they have to really warrant being dyspneic? You know, so sometimes patients go to cardiology, they have these echoes showing HFpEF and, you know, valvular disease or independently, and they're sent over to us for shortness of breath workup. So it's a little confusing on our end. So I'm hoping you can help us clear that up.
Sure. You know, this is the way I make my living is off seeing consults for dyspnea on exertion. I think what's important to point out here is, like what you alluded to, was the lingo, and HFpEF, HFrEF, but even for the sake of our conversation this evening, we in cardiology, especially heart failure, love acronyms, and we love changing the acronyms every few years. But you'll also hear me use something called HFmrEF, which is for that mildly reduced ejection fraction as well. And that'll play a role in how we approach some of these patients moving forward. You pointed out you get an echo. A lot of times these patients, if they're coming from pulmonology, may or may not have an echo. So that may be a starting point for you, or you may say, hey, I want cardiology to do an echocardiogram. That's fine as well. Yes, that is starting point number one. I know for myself, I'm just as interested in their pulmonary risk factors and their pulmonary history to kind of help build my case. My mentor told me that looking at pulmonary hypertension is like putting one of those annoying jigsaw puzzles together that you would do during summer vacation with your family at the beach. And you're really just trying to throw all the pieces out on the table and get them to fit to really understand what the full picture is. Because I can't underscore how much interplay there is between groups and between disease processes. And I think we've understood a lot more about mixed group pulmonary hypertension. And in some of these patients that look purely group 2 or purely group 3 on the surface, when we actually start peeling the onion layer back, so to speak, we have found out through studies and trials and now guidelines that some of those patients do benefit from group 1 therapy, and where before we wouldn't label them as group 1. But at least we'll tackle diastolic heart failure and heart failure in general. When I'm talking to a patient with heart failure, the classic scenario is, I've been short of breath for a few weeks, maybe a few months. But what's key to point out here is that the remodeling in the heart has been going on for a while. That change in pressure, that increase in LV pressure, the loss of left atrial compliance, and the increase in venous pressure, pulmonary venous pressure, is the nidus for why heart failure causes pulmonary hypertension. From there, we're really dissecting into how much remodeling is taking place in the pulmonary vasculature. Okay. For heart failure patients, it's important for me to figure out where they land. Are they diastolic? Are they mildly reduced? Do they have systolic heart failure? Are there other factors driving why they have systolic heart failure, like coronary artery disease, an ischemic cardiomyopathy? Do they have valvular disease? HFpEF can be a little bit more complicated, and especially now with what we know about a lot of infiltrative diseases, like amyloid, but also we see a lot of patients with hypertensive heart disease, especially young. And I saw a gentleman today with hypertrophic cardiomyopathy. We've got a lot of better understanding of that and good therapies. So all of those scenarios are in play when I'm seeing someone for dyspnea, because I really don't know where they're going to land until I have that echo. So my approach is, I'm standing in the middle of the forest, and instead of having 1 or 2 forks in the road, I have like 5 or 6. And I kind of have to go down methodically each one of these to see which is the best path. What's key here, regardless of what is driving the heart failure, you have to achieve euvolemia before we start working them up on a cardiac perspective. Because the gold standard here, especially if we're suspicious for group 1, is we've got to do that right heart catheterization. Knowing the patient's risk factors is equally as important, because we need to ask, does this patient need an ischemic evaluation? Do they need a left heart catheterization concurrently to look for coronary artery disease? And then from there, we're able to get our hemodynamics that support our decision with therapy and possibly referral.
Okay. So if you were to start working up that dyspneic patient, or you receive them from pulmonary saying, hey, we did a PFT, we did a CT of the chest, checked their oxygen levels and all of that, and everything looks good on our end. We ordered this echo, and we're just seeing HFpEF. There's no evidence of pulmonary hypertension at that point, which we know could be underappreciated with echoes. And oftentimes we don't get, RVSP measurements for various reasons. But let's just say we're not at this point thinking pulmonary hypertension in these patients.
Sure.
How much diastolic dysfunction or how much HFpEF could we see and say, okay, that's likely the root of their problem?
I think it's important to point out that heart failure is a big blanket term. Congestive heart failure is a big blanket term that a lot of patients get assigned to. It's not really a diagnosis as much as it is a constellation of symptoms. So I think that's important to point out, because especially with diastolic heart failure, HFpEF, your echocardiogram may not show diastolic dysfunction. That doesn't necessarily mean they don't have heart failure. That's an important distinction. They may have some just very benign appearing, what we report as pseudo-normal relaxation, diastolic impaired filling, diastolic filling pattern. These patients could have pretty significant LVH, which is making you go down the HOCM, hypertrophic cardiomyopathy pathway. So a dyspneic patient with risk factors that doesn't show that your pulmonary workup doesn't explain their symptoms. Maybe they've had a hospitalization here recently, and they're telling you, yeah, they told me there was some fluid on my lungs, and they gave me a day or two of Lasix, and then they sent me out back into the world. And the patient's sitting in front of you, and they've got a whole bottle full of furosemide. Now, that's a heart failure patient that deserves more workup. But the important take-home point here is diastolic dysfunction doesn't always have to be apparent on the echo to have HFpEF.
I was told by a cardiologist that the left atrium is always a great place to look. If you're not getting if they can't estimate diastolic function in that patient, the EF is preserved, but you've got this big left atrium, that's likely an indicator. Would you agree with that? And would you have any other indicators we could look at the echo that might kind of lead us down that path?
Absolutely. I mean, you have to look at that, as you alluded to, the left atrial compliance. But it's important to point out that your wedge pressure on a right heart cath is your surrogate of left atrial pressure. So that, that's kind of maybe reinforcing your point a little bit later down the line. But if you kind of think of the two the same and how that plays in with peripheral vascular resistance, it starts to really make sense. I like to think of pulmonary hypertension regardless of the cause, but especially with group 2. And the way I explain it to patients is a garden hose. If I pull your heart and your lungs apart, this is nothing but just a basic garden hose that you get at Home Depot, separated by a few valves. And somebody is putting a kink in this garden hose, and there's something driving that. So yeah, it's looking at pressure, understanding, and really tracing your steps backward, if you will. I agree with that. Yeah.
Are there any other echo indicators that would, from the cardiology side, that you would look at and say, this likely is a rabbit to chase, this likely is causing or maybe a contributor to their shortness of breath that may not just be blatantly evident to the rest of us, that you would see on an echo with, no pulmonary hypertension, but you would look at and say that's suspicious?
Sure. Somebody that may be presenting to you with heart failure symptoms, maybe they have a little bit of RV dilation that you really can't account for. Their RVSP may not be significantly elevated, but they've got something that's driving that RV to dilate. They may have a degree of tricuspid insufficiency. The RA may be dilated. They may have IVC dilation. Those are definitely things that I look for, because you can't always explain those. Why does someone who is otherwise seemingly fairly healthy, who's complaining of dyspnea, that it doesn't have, let's say, endocarditis or a reason to have tricuspid insufficiency, no congenital heart disease, nothing like that. You have to start really questioning, well, hey, is my echo enough? Why am I seeing this degree of right-sided dysfunction? Is there something going on in the pulmonary vasculature? And that's why I really point out, not only for later on a right heart catheterization, but really looking at these studies like an echo when a patient is euvolemic is important, especially when we talk about valvular disease. A patient, for example, let's take severe MR. Their MR is obviously going to look much worse when they're in a decompensated state. You want to get them euvolemic and then re-image them and really see the degree of pulmonary hypertension and right-sided disease.
I'm so glad you said that, because I was just having this discussion with one of the nurse practitioners in my practice today. She said, how much mitral valve disease do they need to have to really be the root of their pulmonary hypertension? And let's just say in a euvolemic patient, I mean, could we blame that as a source of pulmonary hypertension if it's moderate? Does it have to be severe?
I think moderate to severe. Rule of thumb, at least with, I know when I started practice, my supervising physician told me, he said, look, if you want to err on the side of caution for anything with an echo, anything moderate or greater deserves your attention. So
Okay.
I do believe moderate MR, yes. I've seen people that are symptomatic. Those are not people that are needing any sort of valvular intervention at that point. But yes, that is enough to cause pulmonary hypertension. It is enough to cause symptoms.
And specifically in a euvolemic state, right? Because
Yes.
we get patients, sent to us with for pulmonary hypertension referrals, and they were in the hospital in left-sided heart failure, pulmonary edema, hypoxic for the first time ever, and we repeat the echo, get them euvolemic, and the pulmonary hypertension generally improves. So the same thing for valves, I didn't really think about, is that if they're decompensated and have terrible looking valves, repeat the imaging. I'm sure cardiology would do it anyway, but let's just say cardiologists fall off the face of the earth, then we would repeat imaging once they were euvolemic and see what those valves look like.
Exactly. Typically, because a lot of times this is occurring, valvular disease can be isolated for sure. This can be primary versus, if we want to focus purely on mitral regurgitation here, is this primary, is this functional MR, is this secondary MR, where does this fall? Sure, you can have isolated valvular disease independent of heart failure, but more often than not, we see it concurrently with heart failure. Those are patients I want to make sure I've got on guideline therapy, depending upon what their EF is, dry them out completely, and then look back. More often than not, their MR is not as severe. Now, if they've got something else going on, let's say they have, I had a lady I saw in follow-up, she had a ruptured chordae. That's not going to get better. She comes in with acute heart failure. Her MR is going to be just as bad. She has an anatomical issue that needs to be fixed. But a lot of these patients, once you get them on good medication, you dry them out, you really decrease that vascular resistance. You will be surprised with how much that they actually improve.
Okay. Well, while we're on the topic of valves, we also see these echoes where there's no evidence of diastolic dysfunction, right heart looks good, but we have all these leaky valves, and sometimes it's all of them, and they're all mildly, regurgitating. Could that be a source of their dyspnea? Is that enough to make them dyspneic?
Mild, no. Mild, no. Like I said, moderate is when I start paying attention. Moderate aortic insufficiency. Now, moderate, you're going to say, okay, this is enough for me to pay attention to, but it's not bad enough to fix. Same thing with mitral. Moderate's not bad enough to fix. So these are patients that you could say, yeah, you can certainly have symptoms, but let's get you on good therapies. Let's make sure your blood pressure is controlled. Let's make sure your volume status is optimized. And really just follow them closely to see if there's any change in their valvular disease. I'll give an example of a lady I saw today. She has no non-ischemic cardiomyopathy with improved ejection fraction, previously about 20%, got her to about 50, 55. She kind of fell off the grid for a little bit. Hadn't seen her in about a year. In addition, she had known moderate MR and moderate pulmonary hypertension by RVSP. Did a couple of years ago, I did a transesophageal echocardiogram that confirmed that she had moderate MR. No significant like prolapse of the leaflet or anything like that. Got her on good therapy, continued. She ended up taking care of her husband, who's also my patient, and really kind of let herself not get a lot of good follow-up, unfortunately, for various reasons. She comes to me acutely, more or less worsening dyspnea. Her MR murmur is much more prevalent than it was. So this is a lady that otherwise had moderate MR, was on good therapy for HFrEF, but had progression of her disease and thereby progression of her pulmonary hypertension. So I'm kind of having to hit the reset button. My point with that example is these patients require ongoing surveillance. And you will find cardiology, if you ask 5 different people, you're going to get 5 different answers on how to follow this, unfortunately.
Yeah, we have the same in pulmonary. Yeah.
Yeah. And it's, and I talk with my pulmonary colleagues a lot, we're not offended if people order echoes, to say, hey, you're seeing this patient as well. You may be seeing them more often than we are. Yeah, keep tabs on it because things do change.
Okay.
And that's, it really takes a village to be able to follow these patients for sure.
Well, now that you brought that up, I'm going to ask you a question about what would you like us to know on the pulmonary side? Are there better ways for us to package patients to you? Are there things that we commonly miss? Are there things that you would like us to know about your cardiac patients?
Sure. My workup starts with an echo, and it may end with an echo. I may not need to look further. It's that onion layer that I'm talking about. It's just, we have to look a little bit further, a little bit further, a little bit further. I have the expectation of the patients coming to me that the pulmonary side of the house has been taken care of. One thing I'm finding a lot of is, especially where I live in southeastern North Carolina, the environmental exposures are pretty prevalent. So I see a lot of farm workers and factory workers and people like that's driving. The right heart cath, left heart cath, push for it. If you think your patient needs it, call cardiology and say, I need it. Because I get a lot of second opinions from other cardiologists, from pulmonary, for patients that see other cardiologists, because they're not, pulmonary hypertension to an interventional cardiologist may or may not be a big wow factor because there's nothing to fix.
Right.
So guys that get paid to put stents in people, they don't do it, but they don't do it like they should. But it's a 10-minute procedure. It's so valuable. It's so valuable. The other thing that I would encourage is, and I learned this along the way, is cardiology is not the only one that can do a right heart cath. There's a lot of pulmonologists that are out there, and pulmonology APPs that routinely do right heart caths. And if you're at an institution that supports that, by all means, do it. I think everybody that, whether you're cardiology or pulmonary, if you see patients in the hospital and you take care of pulmonary hypertension patients or you're in the ICU, you should know how to do a right heart cath or a swan and be able to get those hemodynamics. One thing that I do see that's a little bit underutilized, and the chest CT is obviously important to your discipline to look for fibrosis and ILD and all of those things, is some of these patients with rather significant lung disease, if we're really suspicious for, let's say, group 4, CT doesn't help me as much. I need CT as well as VQ. And I see that getting left out of not just pulmonary and where I live, but also cardiology. People forget about the utility of VQ scans. The last is, I've got a checklist that I use. Sleep apnea, all the connective tissue disorders, environmental exposures, and I kind of go down and I encourage, and I'm happy to share that as well. But I feel like you have to basically go line item by line item and cross out, okay, this patient doesn't sit here. They don't sit here. We've got this, because you're just trying to really narrow that focus down. But it also helps you see those overlaps for those mixed group patients.
Yeah, I call pulmonary hypertension a game of whodunit.
Right.
Trying to figure out, it was the butler in the, kitchen with a candlestick, and it's the who, of who groups who've done it when it comes to pulmonary hypertension. And I have to say, I am very impressed, and it's very refreshing to hear someone from the cardiology side talk so much about pulmonary hypertension. I know there are a lot of cardiology practices, institutions where the PH centers are based out of the cardiology department, but it seems like for the most part, the majority are usually pulmonary department ran, and I'll get referrals for pulmonary hypertension from cardiologists who I swear when they're reading the echo are wearing an eye patch, and they won't even look at the right side of the heart. They don't want to know anything about it. It's not their problem. And they will send them to us with any right heart abnormality that they want us to address to work up the pulmonary hypertension. So it's really exciting to hear you talk about that. So let's dive a little deeper into that piece of it. When, group 2, pulmonary hypertension being generally left heart disease, valvular disease, your department, what is the game plan for cardiology when that happens? Let's say they came to pulmonary first. We worked up group 1, 3, 4, and 5, and we said, it looks like it's group 2. We're sending them to you guys. What does your game plan look like when it is group 2?
Sure. Those patients more often than not get both a right and left heart cath. Obviously, if we run into, the patient needs a coronary stent, or we're looking at bypass or what have you, we need to address that side of things. If they have concomitant heart failure with it, we're aggressively titrating medications. HFrEF, we know the 4 pillars, as well as HFpEF. We know the utility like in SGLT2 inhibitors and MRAs and the new roles that ARNIs like in sacubitril valsartan play. That is really becomes our focus if heart failure is there. Because I tell patients all the time, if they have heart failure and pulmonary hypertension, I can't guarantee that I'm going to make your heart better. I can't chase a number. What I can chase is your functional class and keeping you out of the hospital. And that, it's a mathematical fact, keeps patients alive. These medicines prolong life, and they improve the performance of the heart. And that really is where our focus becomes when we're in group 2. Heart failure, make sure they're on the right meds, treat it appropriately, get them in to see an advanced heart failure specialist as well. A lot of advanced heart failure transplant cardiologists serve as pulmonary hypertension specialists at their tertiary facilities. So they are well versed in that arena. If you've got a patient with coronary artery disease, you can be talking about a patient that just needs, like I said, just a stent, or we could be talking coronary bypass grafting, what have you. Patients that are very progressive, let's say they're young, we're really they may have no improvement in their heart. They may be very refractory to guideline therapy, maybe have severe pulmonary hypertension on top of it. Early referral for transplant consideration is important. And lastly, valvular disease. Once you've achieved euvolemia like we talked about, if they've got severe MR and concomitant heart failure, getting them to a comprehensive valve clinic. And when I say comprehensive valve clinic, severe MR, for example, should be looked at not only by a structural cardiologist, but also a cardiothoracic surgeon, deciding what is the best for this patient. Is it a valve repair? Is it a replacement? Is it a minimally invasive procedure like a mitral clip? Does this patient have congenital heart disease, and we need to bring back in a pediatric or congenital heart specialist to help us with this management. So one thing that I definitely would say is you're not to disparage the general cardiologist, because that's my arena. I'm not at a tertiary facility or a part of a heart failure clinic, but not being so proud that we can't ask for help. Even though you may be sending the patient to us for further workup of group 2, we may identify something that the patient needs tertiary referral. And that's important, especially when we're talking about valvular disease. And valvular interventions, if you have a patient that needs a transaortic valve replacement, needs a mitral clip, these need to be done at centers that are very high volume.
Great. Yeah, I completely agree. There have been times where we've had patients come from rural areas and they have echoes showing moderate to severe aortic or mitral disease, and they've just been watching it. Their cardiologist has just been watching it because they're in a rural clinic and maybe they just don't have access. And, I would definitely refer them on to CT surgery just to at least get if they haven't seen a surgeon, at least just to get that opinion. And so I think that's important for people to hear, is that if their cardiologist isn't being terribly aggressive, you feel like the patient's progressing, definitely can reach out to the other members of the team.
Absolutely. And I would advocate almost, depending on where folks practice, to, before you get in a situation like that where you're having to really kind of escalate care, have these conversations with your go-to cardiology team. And really kind of almost come up with a contingency plan for some of these more complex patients, because they will come up. It's, like I said, I'm in a large community hospital. We're not an academic center. So I don't have the luxury of, basically a team-based visit or group visits where a patient is seeing me, may see pulmonary hypertension specialist, may see cardiac surgeon, and a structural cardiologist all in the same visit. But being able to have that contingency plan in place of how you would approach that patient you're alluding to. Someone comes to me with severe aortic insufficiency, severe MR, my antenna goes way, way up. This is not somebody that I've got, 4 to 6 weeks to really drag out and get an answer. I've really kind of got to get on my horse and go.
Question for you about your group 2 patients with pulmonary hypertension. Is there benefit on your side or data that you guys have? I have not read anything regarding cardiac rehab in those patients. Do they have benefit? Do you push them towards cardiac rehab?
They absolutely have benefit. Cardiac rehab, I think, is very important, not just in your CABG patients, but in these individuals as well. I'm a big advocate for it. I know all of my patients, I do inpatient as well as outpatient. When I'm seeing patients in the hospital, let's say they may not have pulmonary hypertension. They're purely a heart failure patient. I'm talking to them about pulmonary hypertension, about cardiac rehab. I would really encourage gauging the functionality as well as kind of the support structure for that patient, Um, if I get somebody who's 40 years old, who may just be unfortunate to have been dealt bad genetics and has hypertrophic cardiomyopathy, but otherwise is able to, is pretty functional and has a good exercise plan, that's somebody I may not say, I may let slide. It is a case-by-case basis, but generally I do advocate for it, and I encourage others to do so as well.
Okay. Last thing I'm going to pick your brain about. There was an article this month, which we're recording this in March of 24. There was an article this month in Chest Physician magazine. It was in the Chest Journal, and it was talking about comorbid pulmonary hypertension. And they talked about group 2, doing a right heart cath, seeing that, wedge pressure around 15-ish or so. And they kind of look a little pre-capillary, but they've got all this group 2 disease, and considering a trial of putting them on PDE5 inhibitors. Is that something that you guys are doing? Do you usually try to avoid? Because we know that PDE5 inhibitors are not indicated for group 2 disease. However, there has been this leaning talking about overlapping conditions of, if we feel like there could be still some precapillary disease, that we would consider that as a monotherapy, being not a straightforward group 1 patient where we want to do dual upfront therapy. So where do you stand on that?
So I have mixed feelings about it. I did read that article, and a lot of it depends on who you talk to. I personally do not do it, but that doesn't mean to say that I will never, if that makes any sense.
Yeah, it's a very gray area.
It is a very gray area. Because a lot of these patients need or do become very complex, if I am considering therapy of any kind, I actually do have them see a comprehensive pulmonary hypertension clinic at a tertiary facility, because I do think that the landscape, like I alluded to earlier, with mixed disease is evolving. I feel like every meeting we go to, we're getting something new. There's a new therapy. We're talking more. I mean, now there's medications for group 4. I mean, there's all sort. The landscape is just changing rapidly, and more importantly, one of the ways we know so much is to get these patients into clinical trials as well. And getting them in touch with these tertiary comprehensive clinics to be able to talk about enrolling them in a trial, I think is also equally as important. So we are able to have conversations like this.
Right.
But it's more often than not, I see a lot of mixed group. Some of the pulmonologists that I do work very closely with in pulmonary APPs, are pretty comfortable with pulling the trigger with the PDEs, and I support that. But I still do advocate for them being evaluated. If we are considering putting them on a PDE4, do we need to stop there, or is there some support for other therapies as well?
Mm-hmm. Yeah, it's definitely a complex conversation. Probably could be its own podcast altogether. So.
Oh yeah, and I think it's important to say that even though these patients, and this is purely anecdotal. I remember when I was in school in endocrine, they said, well, all type 2 diabetics eventually become type 1 after a while. Well, makes sense if you think about it. I kind of question, does the same thing happen here? When we start to see a lot of that remodeling very aggressively, I mean, I think going back to the landscape changing, how does that change in this pre-capillary world in remodeling over time? And I believe that we will see a lot of these patients and a lot of these indications for these medications start to expand, which is good news for individuals that we may have only labeled as group 2 or group 3.
Right.
That later on down the line, they may have developed a group 1 component.
Absolutely. Yeah, it's definitely changing, and new drugs are coming soon that address that remodeling process. And how is that going to play? And is that going to spread over different groups? So yeah, a lot to come in that area for sure. Well, Brian, thank you so much for joining us today. You answered a lot of our questions. I really appreciate you going through all of that with us. And to everyone listening, make sure you like, subscribe, and follow the podcast. And Brian, I hope you have a great rest of your day.
You too. Thank you very much, Corinne.